Hi everyone, this is Dr. Stefan. Welcome to Interstitial Lung Disease Info. In this episode, I'd like to discuss about something really important, that is genomic testing or genetic testing for interstitial lung diseases or pulmonary fibrosis. And I wanted to make this video for a long time. It may be a little bit longer because it's a very complex field, but it's really emerging. It's really something that we will have to consider looking at more and more. And the interpretation of these tests is really complex. So basically, let's talk a little bit about genes. We all know about the DNA being this long string of code, and we all think that this bit of code this gene will lead to this protein being produced, and that will have a role in the body. Well, it turns out that it's actually a more complex situation than that. As the more we uncover, it's a bit of a rabbit hole that we go into. There are gene-environment interactions. So the way our genes are expressed is not always the same. So stress levels, diet, our lifestyle, other conditions that we have, the environment, what we're exposed to, all of these things can play a role in whether a predisposition that we have maybe in our genes will become expressed as a condition. So things are a little bit complex in this field. So that's why I would really urge you, if you are undergoing genomic testing for interstitial lung disease, pulmonary fibrosis, or any other reason, to discuss this carefully with your healthcare providers and get an interpretation in the right context for you, because my video here will probably only cover general information that probably will be helpful. So apologies if this will be a little bit of a longer episode because I need to cover quite a lot of things. But I think you need to interpret these in your own context. So what will I discuss? I will discuss about when we do genetic testing or genomic testing for interstitial lung disease and pulmonary fibrosis, what type of tests are there, and a little bit on the interpretation of gene panels, telomere length. I'll explain what this means in a little while, and the role of genetic counseling, which is really, really important. And then sort of at the end, conclude a little bit on the important topics. So basically, when would we do genomic testing for interstitial lung disease or pulmonary fibrosis? We tend to consider this when our patients are quite young. So generally below the age of 50, we wouldn't expect someone to develop pulmonary fibrosis without a known reason. So that's when we would maybe consider that there is some kind of a genetic predisposition in that case. We may also consider it when there are other cases in the family. So for example, other first-degree relatives with interstitial lung disease or pulmonary fibrosis. So for example, father, brother, sister may also had pulmonary fibrosis at some point in their life, being diagnosed with something like that. So for example, a few family members having idiopathic pulmonary fibrosis, especially at a younger age, would be some kind of a trigger for us to consider going down the route of genetics and whether there may be a predisposition there. We may also sometimes, though, encounter situations in families in which someone, for example, has pulmonary fibrosis, but other family members do not have pulmonary fibrosis or lung disease, but they may have other associated conditions that we think share a genetic cause. So for example, there may be cases of blood disorders in the family, such as leukemia, anemia that requires transfusions, things like that, autoimmune disease that's quite common in the family, frequent cancers, early menopause, so female relatives who may go through the change maybe in their early 40s, 30s without a known reason. Or sometimes this is a little bit of a strange one, and please do not worry immediately about this, but things like having early gray hair, say in their teens, early 20s, that's also in the context of these other things. So when we say yes to many of these things in the family, we find all these features, we may consider there may be a genetic cause. So we may look for it. Now, that doesn't automatically mean that everyone else is at risk in the family. So we need to be very, very tactful when we discuss genomic test results in this type of, in this field of interstitial lung diseases and pulmonary fibrosis, because it's very, very complex. It's not as easy as in other fields where we say that we find a gene variant mutation that will automatically lead to disease. It's not as clear cut. So always please consider going for genetic counseling if you do get a result that's like positive for some kind of a genetic change. So it's really, really important. I try to emphasize this every time I see patients with familial forms of ILD, that we need to look further. We need to find the right explanation for you in your context of what this predisposition may mean and what it may mean for other family members. So always don't jump to conclusions if you can. Now, We may do certain tests. So what would we do? Generally, we look at telomere-related genes, surfactant-related genes, or a telomere length measurement. So these are generally the tests that we may encounter in the field of pulmonary fibrosis. Now, what do these things mean? Now, let's talk a little bit about the telomeres, because this is really important, especially in this field. Now, the telomere, if you imagine the DNA code as a long shoestring, and the end bit is basically the telomere. Now, that's a repetitive sequence of DNA. It's not known at this moment to code for a certain protein. So we're thinking that that is basically a bit of a timekeeper for the cell. And as we age, the telomeres get progressively shortened. But in patients who have some predispositions in their genetic code, or maybe related to some things in their life, the telomere may shorten faster. And once it reaches a critical shortening, it may lead to genomic instability. So that cell that has very, very short telomeres may have to be eliminated by the body's defenses because it's an abnormal cell. It's not behaving in the right way. So this telomere shortening, which can be variable in different parts of the body, so this is why it's really, really complex, may actually be a sign that there is a predisposition to getting pulmonary fibrosis, among other things. So it can be associated with other conditions. And then we look at telomere-related genes, which is basically looking at a panel of genes that may be linked to maintenance of the telomere length. So there are protective proteins that kind of are around which the genomic code is wrapped around. So if those are abnormal, sometimes the telomere may shorten faster. So we can look at some of these predispositions as well. And then surfactant related genes are basically genes that are related to producing proteins that make up the human surfactant, which is basically like some kind of a film on the inside, on the inner lining of the alveolar sac. So that's the very end bits of the lung. And when that's abnormal, it may lead to a host of lung problems. So this is generally what the tests that we do are about. Now, where are these tests performed? There are several centers around the world. There are not that many because it's an emerging field, but actually there may be different tests available in different countries or parts of the world. Sometimes they may be free, so covered by the health system in that country, or sometimes patients may need to pay out of pocket to get these done. And it's important then to have an interpretation because genetics is a very, very complex field. So this is a huge problem because we may easily do a genomic test, we may get a result, but we don't know what to do with it unless we have the appropriate counseling. So this is basically a little bit of a background. Now, I've told you about the most common tests, so the telomere-related genes, surfactant-related genes, and telomere length. Now, let's talk a little bit about what we might do in practice. So when we talk about these genes that are surfactant-related or telomere-related, these may be included in a gene panel test. Now, these gene panels may be different from the center, from center to center, or from country to country. So at the moment, for example, in the UK, I can tell you that we do a panel of around 25 genes that are related to these telomere surfactant variants, so genes. So basically, when we do a gene panel, what happens is that we only look at a specific set. So like I said, around 25, or depending on where you are in the world, it may be more or less. We look at this panel, so a set of genes. So the genetic pathologist will only look at these genes rather than the whole genetic code, because that can be very, very complicated, and I'll explain in a second. So when we do a gene panel test, generally we need this genetic scientist or genetician, genetic pathologist, who will actually look at the sequence and try to figure out which ones are important, which changes are important. When this test is being done, generally we do a sequencing of the DNA, but generally it's not done to the whole DNA because that can be very, very expensive. So we call that whole genome sequencing. So that can be sometimes done. In some situations, more often than not, there will be a whole exome sequence being done. So that just means that we will basically look at the genes. We will read the code of the genes that actually get turned into RNA and then further on into proteins. So we're looking at a smaller subset of the whole genetic code, if that makes sense. So hopefully you are following me on this. But basically, we are reading the sequence, And then once we have had the sequence, that is compared to reference sequences of DNA. So these may have come from, for example, the Human Genome Project, where we read the exact code of the DNA for people, and then basically we compare what we find in a patient with a genetic potentially predisposition to ILD or pulmonary fibrosis and compare it to this reference genome of a person who maybe doesn't have that condition. And then the problem is that we find when we do one of these panels, even if we are looking at, just a little number of genes, small number of genes, we may find a lot of variants, we call them. Now we're moving away from using the word mutation because mutation just implies something bad automatically, and actually the variants are common. They're very common to find variants because, for example, myself, you, someone else, we'll all be different due to genetic variability, ethnicity. A lot of things may play a role. So for example, when we sequence a human genome, we may find, for example, 100,000 variants. So we may have 100,000 small differences between us, but which one is actually responsible for causing a problem in the lungs can be very hard to find. So basically, that's why we need the genetic pathologist or scientist who will try to filter the variants that are found, narrow them down to this gene panel that I was saying that we are testing for. So for example, 25 genes, 37 genes, whatever the panel is in your country or your center. And it's like a bit of a funnel. So we're trying to filter down to the ones that may be common culprits or previously described in the literature as being related to pulmonary fibrosis in some way. And generally that's being done by comparing some of the variants that we have filtered down to reference databases. So one of them would be called, for example, ClinVar. So this is just something that you probably don't need to know about too much as a patient, but it's something that we think about as physicians, as geneticians working in this field. And then the variants that we have found in that panel that we filtered down to, for example, that's genes related to pulmonary fibrosis, let's say, we would then have to classify these variants found as pathogenic, likely pathogenic variants of uncertain significance or VUSs, likely benign or benign variants. So now most of the things that we find will probably not be pathogenic, or as we say, this is a word that means that causes disease, pathogenic. So this is where it becomes a little bit tricky because there has not been that much genomic testing done in the field of interstitial lung diseases and pulmonary fibrosis. So some of these variants of uncertain significance, for example, may still be actually a relevant predisposition, but we just don't know. So that's why genomic testing, as we do more of it, we learn more. And as we do more family studies, we may actually find out what's going on and which ones are relevant. And the thing is that only the pathogenic or likely pathogenic variants will likely be reported by the genetics lab, because these are the ones that may have an explanation associated with them. But we do not know all the causes for pulmonary fibrosis yet. So that's why sometimes we are unsure what to do, for example, with the variants of uncertain significance. And in these situations, the genetic pathologist, the genetic counselor, the physician who's looking after the case may think about maybe testing more relatives with the same disease to see whether that specific variant pops up across the generations, across many different relatives. And if it's present, it could actually explain the disease, even though it hasn't been previously described. So it's actually a bit of a detective work to look into these panels, filter down to the variants that we find, and try to figure out which ones are relevant for our patients. So this is where it is. Sometimes it can happen that we get more than one hit. So for example, in those situations, we may find different variants which are considered pathogenic, but in several genes of that specific patient. And in that situation, we really need to talk to the genetician to figure out which one is plausible to be causing the condition or to be a known predisposition for pulmonary fibrosis, depending on the protein that's affected and what the role of that protein is in the lung. So this is where it becomes a little bit complex. And we also need to discuss with the genetician how these variants are inherited, because sometimes they can be inherited in a 50-50 manner, so 50-50 chance of getting it in the next generation and so on. So really narrowing down what the variant means in your specific case is really important, because it will determine what we do next and whether other family members are at risk and what is the risk for them. So this is why we need genetic counseling. So genetic counseling is a way in which to integrate these results, these findings, into the bigger picture. So this is really, really important. So please, if you are having genomic testing done, do ask that you see a genetic counselor at some point, because they will try to draw out your family tree, try to figure out where the variants pop up among the family members, in generations, and how these are inherited, because then we can work out the risks and determine who else needs to be tested, what they can expect, depending on what is found. Now, let's talk a little bit about telomere length. And apologies if this has been a little bit long, but please feel free to ask me questions in the comment section below. I'll try to clarify it in future videos, or to go back and re-listen to this bit if it doesn't make sense. But I'm trying my best to clarify a very complex situation. So let's talk about telomere length. Now, I mentioned that the telomeres are the end bits of the chromosomes that tend to shorten over time. Now, the problem is in pulmonary fibrosis, if we reach to critical shortening of the telomeres compared to healthy controls, let's say, like healthy people, we may have a higher risk of developing all kinds of conditions, including pulmonary fibrosis. But when we measure telomere length, which can be done by different techniques, which are more or less validated, so it's important what technique the lab uses, we would then have to work out whether that shortening of the telomere is indeed shorter compared to people of the same age, because telomeres shorten with age. So someone who is 80 years old will naturally have shorter telomeres than someone who is 30 years old. So basically the telomere length needs to be corrected to age and compared to what we would expect in a healthy individual without those conditions that we're looking for. And generally, it's good to do the telomere length measurement together with the gene panels that we were discussing before, because it will help us integrate whether some of the predispositions that we find in the gene panel in the telomere-related genes, the genes that generate proteins that protect the telomere, if those are the cause for the telomere shortening. Because if we find a predisposition in the gene panel and the telomere is also short, it's likely that that's the cause of the condition, if that makes sense. Sometimes we may have a short telomere, but no pathogenic variants are found in the gene panel. That's when we are potentially looking at an unknown cause, a novel cause for telomere shortening, which could be investigated further as part of research projects and other things. And those patients may still have a higher risk for developing pulmonary fibrosis in that family, because the telomere is short. So we don't know the cause, but it may still be relevant. So this is why both of these tests, the gene panels and the telomere length measurement, are important in this field. Now, as I said before, this is an evolving field. So as we do more and more testing, more genomic testing in the field of pulmonary fibrosis or interstitial lung diseases, we'll identify more and more pathogenic variants as we're doing more and more family studies to determine how these things are transmitted through generations and what the predispositions are. We may uncover more causes for telomere shortening and how these cause predispositions in family members. So I would strongly recommend that if you are going for genomic testing for interstitial lung disease or pulmonary fibrosis, that you consider taking part in research projects or giving some blood samples to a biobank where local researchers can look at these things further, because it will really advance the field and allow us to develop better diagnostic tools. Now let's summarize this a little bit, because it's been a very long video. We're coming up to, about 18 minutes now. And it's all quite complex. So in a nutshell, we have certain pathogenic variants, so changes in the genetic code that are potentially the cause of a condition of pulmonary fibrosis. And these may contribute to the risk of ILD. So if we find a pathogenic variant in someone who has pulmonary fibrosis, it's possible that that could be the explanation. Some variants will confer a higher risk than others, depending on the variant, depending on the protein that's affected. And also, depending on which variant is found, there may be a higher or lower risk of developing any other associated conditions. For example, I was mentioning at the beginning, blood abnormalities, things like myelodysplasia, leukemia. People may be at a higher risk for these conditions in association with pulmonary fibrosis if they have certain variants. Then it's really important to have genetic counseling. So input from a counselor who will work out the risks in your particular case. And that's why sometimes I strongly advise to avoid online services that allow you to test your genome, because what can happen is that you may get in the mail a little swab, you swab your cheek, you send it off to a lab, you receive a report with all the variants that were found. But if we do not explain this in the right context, it will not mean much. So that's why you really need to work out for the condition that we are looking at, for example, pulmonary fibrosis or other associated conditions in your family. We need to work out whether the variants that we found in our tests are relevant in that case. So genetic counseling is really, really important. And then obviously, telomere shortening is also a known factor. So if we have the opportunity to do telomere length measurement, this could actually help us understand whether that patient may be at risk of developing early ILD or pulmonary fibrosis, whether other related conditions could appear. And patients who have short telomeres may actually progress faster in their pulmonary fibrosis. There may be problems tolerating certain drugs, certain medications such as immunosuppression, which is sometimes given in certain cases of interstitial lung disease. And some patients may actually require an earlier lung transplant referral because we anticipate a faster progression. So actually the genetic testing can help us to determine what's the individual risk for each patient to get worse over time. And like I said, it's very, very complicated. I hope I've done a decent enough job at explaining this in around 20 minutes. If you have further questions, do leave them in the comment section below. I will probably stop here because it's already been a very complicated video, more complicated than the ones that I normally do. Feel free to rewatch it, ask me questions, and discuss with your own healthcare providers, because that's the most important thing, to integrate whatever results you get from the genomic tests into the wider context, which is your own health. Thank you very much for watching, and I wish you all the best and good health.